Hi, my name is Ashlyn, and for my extension project, I chose to look at the physiology and psychology involved in the fluctuating hormone levels during the menstrual cycle. So, for anyone who doesn't know, the menstrual cycle is the shedding of the uterine lining in response to an unfertilized egg post-ovulation. The cycle is roughly 28 days, but it varies slightly among individuals, but menstruation always marks the start of day 1. It's split into two broad phases, the follicular and the luteal, with ovulation occurring between these two. The menstrual cycle is regulated by many different types of hormones, and those can be released from the hypothalamus, the pituitary, or the ovaries, but I will be focusing only on estrogen and progesterone, which are produced and released in the ovaries. So here is a very important diagram of the estrogen and the progesterone levels throughout the 28 days of the menstrual cycle. There are 3 areas I will be focusing on, which are late in the follicular phase when estrogen is very high, in the middle of the luteal phase when progesterone is very high, and in the premenstrual phase when both hormone levels are very low. So, during the late follicular phase, estrogen levels are very high, and estrogen has been linked to the following effects. First is a decrease in appetite, which is hypothesized to occur in 2 different ways. First is that estrogen can act as a neurotransmitter, and so it can bind to an area of your brain involved in satiety called the paraventricular nucleus. This is in your hypothalamus, and when it binds, it sends signals to your body that you're full. The second way is by increasing the effectiveness of a satiety-inducing hormone called cholecystokinin, which we talked about briefly in class. Estrogen has also been linked to an increase in serotonin levels, and serotonin is typically associated with feelings of happiness and well-being. The likely mechanism by which it does this is inhibiting the serotonin reuptake transporter, which allows serotonin to stay in the synapse for longer and exert its action. And you might remember from class that this is actually the same mechanism that SSRIs use. And then finally, estrogen has also been linked to an increase in dopamine levels, which it does by inhibiting the dopamine transporter and allowing dopamine to stay in the synapse for longer. You might recognize that this is a very similar mechanism to serotonin, and it is, except that increased dopamine is instead associated with increased motivation. Moving on to the mid-luteal phase. This is post-ovulation when progesterone levels are very high. And progesterone has been linked firstly to an increase in appetite, although the mechanism by which it does this is not as well understood as that of estrogen and appetite. It could possibly be linked to an evolutionary shift in priority from reproduction in the follicular phase to eating after ovulation has passed and reproduction is no longer as important. High progesterone has also been linked to decreased anxiety, but this mechanism is slightly more complex than the ones we discussed previously. So when progesterone is broken down in the body, one of its metabolites is called allopregnanolone, and allopregnanolone is able to increase the inhibitory effects of GABA in the amygdala. And if you remember from class, the amygdala is responsible for much of our emotional processing. And so when GABA is upregulated, there's an overall decrease in signaling in this part of the brain, and this is associated with decreased anxiety. However, on the flip side, progesterone has also been linked to an increase in cortisol levels, which you might remember from class is the hormone we typically associate with stress. And this is because progesterone is a precursor for making cortisol, and so when you have more readily available progesterone in the body, there will be more readily available cortisol for when our body needs to respond to stress, and so more cortisol is released. And finally, we have the premenstrual phase, during which there is a sharp decline in both hormones leading up to the days before menstruation. It's often associated with feelings of decreased motivation, mood swings and irritability, and changes in appetite, such as specific cravings. And while we're not sure of the exact mechanisms by which these psychological symptoms occur, we do know that both our dopaminergic and serotonergic pathways are affected by these shifting hormone levels, and this likely plays the major role in these symptoms. Now I'm going to diverge just a little bit and talk briefly about premenstrual syndrome and the more severe form, premenstrual dysphoric disorder. These conditions are characterized by an above average severity of symptoms that occur with the normal fluctuating hormone levels that are experienced during the menstrual cycle. And so, while we're not exactly sure what causes PMS and PMDD, we do know that it is not due to higher than average levels of estrogen and progesterone, as these individuals have hormone levels within the normal range. So, it's more likely that they just have an increased sensitivity to estrogen and progesterone. And one study even found that individuals with PMDD have an increased sensitivity to the progesterone metabolite allopregnanolone. Other studies have also been completed on whether or not there is a genetic component involved in PMS and PMDD, and to tie in a few concepts from class, they found concordance rates to be higher in monozygotic than in dizygotic twins, indicating that there is in fact a genetic component. And various studies have found heritability estimates between 35.1% and up to 56%. Okay, that is all I have, and here are my references if you're interested in learning more. Thank you.